year's webinar series on science, practice, and policy, I think, gives us an opportunity to really begin to look at issues that are affecting women, children, and families across the country. And this first one, of course, has received a lot of attention from an epidemiologic and medical perspective, and that is neonatal abstinence syndrome. As we begin this discussion, we have to make sure we all understand the definition of neonatal abstinence syndrome. NAS is comprised of the signs and symptoms that occur when a newborn prenatally exposed to opiates experiences opioid withdrawal. Now, why I emphasize opiates is that you'll go into some state policies and they expand NAS to include other exposure to other substances, and that is completely incorrect. For a child or an infant to have neonatal abstinence syndrome, that refers only to opiate exposure. Now, there is some discussion that alcohol exposure to benzodiazepines can produce an abstinence syndrome, but it is not the same as that when infants are exposed to opiates prenatally. So I just want to make sure that we all understand we're talking about NAS in the context of prenatal opiate exposure. Now, this is nothing new. If you look at the history in the United States of opiate use, we see historically a cycling. In the early 1900s, heroin was very popular. But then you see it begin to fall off, and as the use of heroin begins to fall, you get more of the use of stimulant medications. If you bring it up into the more recent history, you see that in the 1970s, there was quite a bit of opiate use, and especially heroin, and heroin began to fall away, and we started seeing more cocaine use. Well, as cocaine use began its down cycle, heroin use came back. As heroin use began to fall off, we saw methamphetamine. And now as methamphetamine use has become less widespread, we saw a return of opiate use. What is different this time, though, is that quite a bit of the opiate use is related to prescription medications. And the other thing that differs now than from what has occurred historically is that we see polydrug use patterns. So even among women, pregnant women who are using prescription medications, you still see a high rate of use of especially alcohol. Now, the incidence of neonatal abstinence syndrome has been studied pretty extensively now. The most recent studies have looked at neonatal ICU admissions. And per 1,000 admissions, you can compare data from 2004 to current data 2013. And you can see that the rate of NICU admissions per 1,000 admissions has increased significantly, so that the most current data we have show that almost 30 admissions per every 1,000 are due to NAS. The other important aspect of this is that the length of time in the neonatal ICU is increased from about 12 days in 2004 to almost 20 days in 2013. The percent of NICU days attributed to NAS also have significantly increased, and the number of infants, or the percentage of infants with NAS who have required medication, also has increased. Looking at the cost of NAS, from 2009 to 2012, there has been a significant increase. In 2009, it was estimated we were spending $732 million a year nationally to address neonatal abstinence syndrome. And now, the most current data from 2012, that cost has risen to $1.5 billion per year to treat NAS. And it's important for states to realize that 81% of the costs attributed to NAS are borne by the state Medicaid program. Geographically, we do see differences in distributions. The highest rates are in Kentucky, Tennessee, Mississippi, and Alabama, about 16 NAS infants per 1,000 live births. The lowest rates are in the middle of the country, Oklahoma, Texas, Arkansas, Louisiana, with just 2.6 per 1,000 live births. Now, this distribution is something that's changing constantly. So what does neonatal abstinence syndrome look like? The onset can be at birth, depending on when the woman last used an opiate and what the dose was. Usually, neonatal abstinence peaks at around 3 to 4 days of age, and that acute phase lasts up to about 6 weeks, following which is something that we termed the subacute phase in a paper we wrote back in the 80s referring to neonatal abstinence syndrome, that there is a subacute phase. Once the infant has recovered from that acute phase, we still see sleep disturbances, feeding problems, irritability, up to 7 to 8 months after delivery. I'm sure most of you are familiar with the symptoms of neonatal abstinence syndrome. Basically, you can think about it as an infant exhibiting the same withdrawal symptoms that an adult would show when withdrawing from opiates. Neurologically, the newborn infant is hypertonic, that means quite stiff, can have tremors, be hyperreflexic, very irritable, often with a high-pitched cry, sleep disturbances, and sometimes seizures. The baby's skin is rubbed raw, especially the elbows, the knees, and the chin from rubbing on the sheet of the bedding. You can see a lot of yawning and nasal stuffiness, sweating, sneezing. Often the babies run low-grade fevers, and so many times have to be worked up for possible sepsis, though most times the low-grade fever is due just to the neonatal abstinence. You'll also see changes in coloration of the skin with blotching or mottling of the skin. The babies frequently are breathing very quickly and sometimes have periods of prolonged apnea. There are gastrointestinal abnormalities with a lot of diarrhea, vomiting, poor feeding, difficulty swallowing and especially coordinating the suck and swallow. And all of this, of course, means that the baby is expending far more calories than he can take in, so that you see high rates of failure to thrive. The therapeutic management of neonatal abstinence syndrome should always start with supportive management. That is, swaddling the infant, especially in a flexed position, offering a pacifier, keeping lighting low. Sometimes an oscillating crib or even a waterbed crib is helpful, and avoiding abrupt changes. Now, of course, the low lighting and the quiet environment is not found in a neonatal ICU. And so these babies often do best in a supportive environment that does not have all the bells and whistles of a neonatal ICU. And there are many hospitals, such as a hospital in Alaska, that have opened special units for these infants so that it is a quiet environment in which the infants can lie undisturbed. Frequent small feedings are best, and at times there are indications for pharmacologic intervention. What is unique about what we're seeing in the current epidemic of neonatal abstinence syndrome is the high prevalence of narcotic prescription medications being used. In a recent study that looked at 1998 versus data from 2008, and what the investigators did is they evaluated the number of cases of pregnant women in which the pregnant woman used a narcotic prescription for at least 1 month during the pregnancy. And that rate went from 2.5 cases in 1998 to more than 10 cases in 2008 per 1,000 deliveries. Importantly, the Tennessee Department of Health recently published a study in which they evaluated 805 cases of neonatal abstinence syndrome. 46% of those cases, the women were on supervised medication-assisted treatment, most often methadone. 39% of the cases were because of abuse of prescribed narcotic medications, and 19% of the women were on supervised pain therapy. And relatively few women, only 28%, were using illicit drugs, illicit opiates, without a prescription. Now, these percentages add up to more than 100% because of poly-drug use patterns. But what's important here is that 72% of the infants who went through neonatal abstinence syndrome, 72% of those infants, their mothers, were on a prescribed medication. Now, as we talk about prescribed medications, one issue that always comes up that is quite important is the issue of medication-assisted therapy. By far, the most common modality is methadone. Now, I know that buprenorphine has become quite popular to use during pregnancy. However, you should be aware that it is not approved by the FDA for use in pregnancy, and there's really very little research that has told us about the safety and/or efficacy of buprenorphine during use during pregnancy, especially as it is related to neonatal abstinence syndrome. So we're going to focus on methadone and look at some of the policy issues around methadone maintenance. Now, methadone is a synthetic opiate. It's an agonist at the mu receptor, and those are the receptors for pain. And when you take methadone by mouth, it is about 80 to 90% of it is available. That is, it's absorbed and is active when taken orally. Its half-life is 18 to 36 hours. Now, this is an important point because heroin's half-life is only 4 to 6 hours. So what you get is a much more level, a steadier state of medication when you use methadone versus heroin. Peak plasma levels occur about 2 to 4 hours after the dose, and its relative safety and efficacy has been demonstrated in numerous studies. So much so that in 1997, the National Institutes of Health Consensus Panel issued a statement that said methadone should be considered the standard of care for opiate-abusing pregnant women. Now, the goals of methadone maintenance are pretty narrow. It's number one, to prevent the abstinence syndrome in the pregnant woman, to reduce or eliminate narcotic cravings, and to block the euphoric effects of the illicit opiates such as heroin. And it achieves this by providing a steady state of opiate levels in the blood. However, there was a study in 2002 looking at methadone and showed that the peaks and valleys can vary quite a bit, all the way from a dose of 35 milligrams a day to 215 milligrams per day. And what this tells us is that there is an individual characteristic of the person who is taking methadone as to how rapidly or slowly that individual metabolizes the methadone. So this requires quite a bit of monitoring, especially as you are starting a new patient on methadone. Now, the advantages of methadone are great. You get less needle use because the individual is using the methadone orally. You don't see the drug-seeking behaviors. You avoid the exposure to drugs of unknown concentration and impurities, especially for those drugs bought off the street. And you avoid the fluctuating drug withdrawal. And all of this is achieved by this steady state of opiate that is provided through methadone. Consequently, because you're avoiding the ups and downs of peak and trough levels of the opiate, the woman is not going through withdrawal. The woman is not suffering abstinence symptoms. You get decreased rates of the most common pregnancy complications associated with opiate use. These complications are spontaneous abortions, especially in early pregnancy, preterm labor in later pregnancy, intrauterine growth retardation, abruptions of the placenta, and fetal meconium aspiration. So all of these very serious complications are reduced when a woman is on methadone maintenance. Now, there are some disadvantages of methadone maintenance therapy in pregnancy. Early studies looking at methadone versus heroin showed that babies whose mothers were on methadone, those infants had more severe neonatal abstinence, more prolonged neonatal abstinence, and higher rates of neonatal seizures. However, when you examine those early studies, you find that pregnant women, were on very high doses of methadone. And in the early to mid-70s and into the 80s, several studies of low-dose versus high-dose methadone maintenance in pregnant women were conducted. The current average dose of methadone is 80 to 120 milligrams per day. And that has gone up in the last few years, so it's not uncommon in our clinical program for us to see babies whose mothers were on 200 milligrams per day. And they, of course, go through very severe neonatal abstinence. Low-dose methadone maintenance is defined as less than 40 milligrams per day. Now, why have methadone doses been rising? There are some pregnancy-specific issues for methadone dosage. We know during pregnancy that there is an increase in fluid space. Pregnant women retain water. There is also a larger tissue reservoir. And there appears to be some increased metabolism by the woman due to variabilities of cytochrome P450 activity, which is responsible in large part for the metabolism of the opiate. And then, of course, you have to consider during pregnancy that there is some level of placental and fetal metabolism of the methadone. So all of this has led over the years to higher and higher doses of methadone being used during pregnancy. Now, there are several studies that I want to call your attention to. In 1977, there was a study of low dose versus high dose methadone. Note that low dose was defined as less than 20 milligrams, and high dose was defined as more than 20 milligrams. And what they found was that there was a significantly higher rate of neonatal abstinence syndrome in those babies whose mothers were on greater than 20 milligrams per day. Now, a second study in 2003 looked at differences in low dose versus high dose, but notice now low dose is defined as less than 80 milligrams per day versus high dose more than 80 milligrams per day. And not surprisingly, these researchers found there was no difference in neonatal outcome, including neonatal abstinence scores, need for treatment, or the duration of abstinence. And then a third study in 2005 also looked at low dose versus high dose, but again, they found no difference in newborn outcome when the mothers were on less than 100 milligrams versus more than 100 milligrams per day. So these last two studies are where many of the arguments about high dose versus low dose come from. These two studies are why many researchers and many clinicians especially, and many in the methadone maintenance industry say that there is no difference for the infant whether the mother is on high dose or low dose methadone maintenance. But again, let me draw your attention to the fact that these two studies used 80 and 100 milligrams as the two cutoffs between low dose and high dose. Perhaps the best study came in 2002. And what this group did is they looked at 3 different levels of methadone dosing. They had 65 pregnant women, 25 of whom were on less than 20 milligrams a day, 20 of whom were on 20 to 39 milligrams per day, and 20 of whom were on greater than 40 milligrams per day. So what they were able to do then is look at methadone dose at 3 different levels versus newborn outcome. And the data are very clear. The higher the dose, the worse the babies did. The first factor was birth weight below 10th percentile. And you can see that if the baby's mothers were on less than 20 milligrams a day, the rate of birth weight below 10th percentile was 4%. At the mid-range dose, it increased to 12%, and at what these authors described as high dose, that is more than 40 milligrams per day, the rate of birth weight below 10th percentile was 30%. How many infants needed treatment for neonatal abstinence syndrome? Again, a steady increase based on dose from 12 to 44 to 90% of babies whose mothers were on more than 40 milligrams per day. Mean neonatal abstinence score using the NAS abstinence score created by Finnegan. The mean score, again, went steadily higher with increasing dose, 3, 7, 11.5, and then length of stay in the hospital from 7 to 15 to 38 days. When these authors used regression analyses or correlation analyses, what they found, as you can see in this chart, is the higher the methadone dose, the longer the baby was in the hospital. And again, the higher the methadone dose, the higher the neonatal abstinence score. I think this gives us very good information as we address neonatal abstinence syndrome and the policy perspectives, because it shows us that the current trend of high-dose methadone maintenance, and we're talking 180, 200 milligrams a day, is contributing quite a bit to the epidemic we're seeing. SAMHSA looked at neonatal abstinence syndrome and a general policy approach that could be used for all substance use during pregnancy. And SAMHSA utilized 5 phases. Number 1, pre-pregnancy awareness of the effects of substance use. Number 2, universal prenatal screening, resulting in enhanced prenatal services for those women who found to be using substances. Number 3, identifying the infant at birth and then providing services to that child as the child grows older and to the parent over the long term. So this was the general outline that SAMHSA laid out in 2009. What I'd like to do today is to look at the challenges that we're currently facing and then lay out a much more extensive and detailed policy approach. The challenges we're facing come in all phases. Preconceptually, there is a lack of public and professional awareness of opioid effects on pregnancy and the newborn. And we find this especially with the number of women who have been on methadone maintenance. And when we begin caring for their children, the women tell us, "My doctor said methadone doesn't cross the placenta, and so the baby is fine." And that's completely incorrect. Methadone crosses the placenta very readily, and as we've discussed, can produce significant neonatal abstinence syndrome. And so we have to get substance abuse treatment providers, especially those who are providing methadone maintenance to pregnant women, to understand the impact of methadone during pregnancy, not only for the woman, but for the unborn child. The second area preconceptually that there is a significant lack of diligence in is the lack of prescription surveillance. Most states are not doing a very good job of tracking prescriptions with no coordination across, for example, any political boundaries such as counties. During pregnancy, although this issue is improving, there still are very few complete SBIRT systems. SBIRT, of course, meaning screening, brief intervention, referral, and treatment. There continues to be a failure to link prenatal and substance abuse care, and there is really a lack of guidelines for medication-assisted therapy during pregnancy. For the newborn, there's an inconsistent and poor quality control in the use of neonatal abstinence screening tools. By far the most popular screening tool is the Finnegan score. It's used in many, many nurseries. But unfortunately, first of all, we find that the score, which was developed only to assess neonatal abstinence from opiates, is being used for babies exposed to methamphetamine, to cocaine, to marijuana, and it is not validated in that way and is of very little use clinically. It is to be used only for babies exposed to opiates. Now, even when it's used only for babies exposed to opiates, if you go into a hospital, you'll find there's very little consistency across providers. It's usually nurses who are providing or who are scoring neonatal abstinence in the newborns, and you find great variation from one shift to another. So as nurses change, the scores change. So there's very poor inter-rater reliability. Most of this is due to inadequate training, so that the way that a nurse is trained on using the NAS scoring tool, the way that nurse is trained is by another nurse who's been doing it for a long time, who then trains that nurse. There also is quite a bit of administrator bias, and we've published studies that have shown the racial and ethnic bias even when doing neonatal abstinence scores. So these are issues that have to be addressed. And then when you get into the hospital, into the medical side of it, there's a lack of consistent evidence-based approaches to the treatment of NAS. Some hospitals rely first and foremost on supportive services for the newborn, but on the other hand, there are many hospitals who jump right away to medication. And even the consistency of medication use within a hospital varies quite a bit, with some doctors preferring morphine, some doctors preferring methadone, and some using benzodiazepines to treat neonatal abstinence syndrome. There are difficulties and challenges within the child welfare system. Although every state has a law that says babies exposed prenatally to drugs with a positive urine toxicology must be reported to child welfare, there is an over-reliance on looking at results of urine toxicologies. And in many cases, even if the mother is positive at the time of delivery, if the baby is negative, that baby is not reported. Chief among the difficulties we faced is the lack of knowledge regarding CAPTA, the Child Abuse Prevention Treatment Act. Federal CAPTA regulations state that any newborn, and the language is affected by, so any newborn affected by prenatal exposure to illicit drugs or alcohol must be reported to child welfare, which then has the responsibility to link the child to early intervention services. This has nothing to do with taking custody of the child. Its whole purpose is to link the child to early intervention services. However, we have conducted surveys in a variety of states, and what we are finding is that the majority of physicians, and in fact the majority of juvenile court judges, are not aware of the CAPTA regulations. From a pediatric perspective, although physicians and other providers are fairly good at recognizing a baby going through significant neonatal abstinence, there's no assessment of the much more subtle neurodevelopmental sequelae, especially long term. And children with prenatal substance exposure need to be followed over the long term, because even the most subtle of neurodevelopmental difficulties can affect long-term outcome. With these challenges in mind, I'd like to present this systems approach to neonatal abstinence syndrome prevention and intervention. And I've numbered the steps so that you can follow along a little more easily. We start in the preconceptional period at the far left of this graphic. And you can see number 1, professional development and education. We have to provide education on the impact of prescription and non-prescription opiate use and abuse on pregnancy and neonatal outcome. We also must promote the use of validated screening and brief intervention approaches for pregnant women, to identify those at risk and to link them to the appropriate level of treatment. And importantly, we have to regulate and provide more oversight to treatment programs that are providing medication-assisted treatment so that there is a consistency in the use of these medications. Number 2, a public health campaign. We have to educate the public regarding the impact of prenatal opiate use, including prescription medications and medications used for MAT. These effects not only must be communicated regarding pregnancy, but also that all these medications, even if it's a prescription medication, these medications, these drugs do cross the placenta and affect the newborn infant. The third area in the preconceptional period is we have to initiate better surveillance of opiate prescriptions in all states. Each state should have an integrated system for monitoring physicians who are prescribing opiates, pharmacies that are filling these prescriptions, and patient prescription records need to be available across counties and other political jurisdictions within the state. We then move to pregnancy. During the prenatal period, as we mentioned before, there must be universal expert services for all pregnant women. Every program should use a validated screening instrument, provide an evidence-based brief intervention, and be ready to refer women to an appropriate level of treatment. If the screen is negative, then that information should also be recorded in the patient's obstetric chart, as well as all referrals to treatment and the needs for treatment. Importantly, one of the biggest barriers to the care of infants with neonatal abstinence syndrome is the lack of information transfer from the obstetric to the pediatric care providers. So all pediatric care providers should review the obstetric chart and record in the newborn chart any factors, including maternal substance abuse, that could affect the health and welfare of that child. This aspect of information transfer must be consistent with HIPAA regulations. But there is no HIPAA regulation that states that pediatric care providers cannot have access to obstetric information. For the newborn, all newborns should be assessed for neonatal abstinence syndrome if there is evidence their mothers used opiates prenatally. All providers should use a validated NAS assessment tool. And there are 2 aspects that are important to this. Number 1, ensure that all physicians and nurses are thoroughly trained on the assignment of scores on the NAS tool and know how to use the tool. And secondly, there should be an annual monitoring of inter-rater reliability within an institution. This means that all providers, whether a nurse, physician, or other person within the nursery setting, whoever is scoring the neonatal abstinence instrument, should be doing this in a way that is consistent with other providers within the hospital or institution. Also, at this level, the treatment of neonatal abstinence syndrome must be consistent and based on evidence-based approaches. There is some controversy as to the best medication for infants going through neonatal abstinence syndrome, but what is often left out of the discussion is the importance of the supportive swaddling and use of pacifier and the other methodologies for helping an infant with NAS prior to using medication. Number 10, the CAPTA regulations are very clear, and every state, in order to get its CAPTA funding from the federal government, had to sign that the physicians and providers in their state had been well trained in the CAPTA regulations and are aware of the CAPTA regulations. But again, from our experience and surveys we've done in some states, we have found very few physicians or other pediatric care providers are aware of the CAPTA regulations. Now be aware, CAPTA does not require removal of the infant from the home, charges of child abuse being brought against the pregnant woman. The only thing the CAPTA regulations require is that if a baby has been affected by prenatal substance exposure, either to illicit drugs or alcohol, it's a mandated report to child welfare, who must then link the child to early intervention services. Number 11, in follow-up care, the child must have full developmental screening. Now, routine use of an instrument such as the Ages and Stages questionnaire or the Denver developmental screen, routine use of those kinds of screening instruments are not going to necessarily identify infants with the much more subtle neurodevelopmental difficulties. So we are in need of a screening instrument that can do that. But in the meantime, clinicians must be aware that there are other ways in which babies can show distress, looking at sleeping patterns, feeding patterns, and the interaction between the caregiver and the infant. This all goes beyond developmental screening in really trying to understand the inner workings of the child, the neurodevelopmental capabilities. Along this same line, any infants who are found to have difficulties should be assessed and should be provided interventions as needed. The research of Anne Streisguth and her team that showed that identifying the infant exposed to alcohol and affected by prenatal alcohol exposure, identifying that infant and getting services before the age of 6 years significantly improves long-term outcome. That can be applied to any prenatally exposed infant, so that we have a responsibility to identify these infants who have been exposed to opiates, assess them thoroughly, and be sure they get the services they need, especially if we can do that in that 0 to 5-year-old time frame. Overseeing all of this is the responsibility of the federal and state legislatures. Let's start with the state. What can states do to address neonatal abstinence syndrome, prevention and intervention? First of all, we have very little data. Very few states collect and track data on the number of cases and the outcomes of substance-exposed infants, and especially infants with NAS. We need to develop these kinds of tracking systems in every state and incorporate child welfare data into this tracking system. Secondly, reimbursement. Medicaid and commercial insurance reimbursement is going to be needed to support screening protocols that screen pregnant women for substance use and screen infants for developmental risk. We need to establish a quality of care at the state level, looking at collaborative efforts to strengthen clinical standards for identification, management, and follow-up of infants affected by neonatal abstinence syndrome and their families. And finally, at the state level, we must ensure that all pregnant and postpartum women have full access to the kinds of comprehensive services they need to address their use and misuse of addictive drugs. We need to be sure that this system operates within the context of a public health approach and by no means should ever utilize a criminal or punitive framework. Looking at the federal level, the federal government needs to look at CAPTA and how it's being implemented across the states. The federal government needs to review national trends in admission of pregnant women and review of public and private coverage for treatment for mothers and infants. This would help practitioners know more about options for responding to NAS. There need to be federal standards for screening and treatment with monitoring of insurers and health providers under both Medicaid and commercial insurance coverage. This could enhance access to treatment and reduce the tendency of some insurers and managed care firms to shorten treatment below clinically indicated levels. We need to coordinate these efforts. In 2015, the Government Accountability Office, better known as GAO, issued a report that reviewed federal interagency coordination efforts related to opioid use in pregnancy and NAS. Not surprisingly, they found there were very few, if any, coordinated efforts among federal agencies. There are several agencies that do address prenatal issues, child welfare issues, and child health issues. All of these agencies need to come together to develop a coordinated and integrated approach to the prevention and intervention of NAS. This is a critical and growing problem, but our concern for it has to go beyond words and must move to action. So I've presented this systems approach to you. So I do thank you for attending this webinar. I'm looking forward to an exciting year of these policy discussions and hope to be in contact with all of you again for our next one, which is about medical marijuana.